Nick Majerison here. Welcome to Top Med Talk. And on today's Top Med Talk, we continue our series of talks taken from EBPOM 2018. This particular talk is Mark Edwards, Fluid Therapy in Emergency Surgery. Have a listen.
Top Med Talk.
Final speaker for the session, Mark Edwards, that you've met already. He's the PI, or should I say the CI, for Floella, and he's going to be speaking to us about the Floella trial and fluid management in emergency laparotomy.
Indeed. Thank you very much, Tim, for the kind introduction, and thank you to the organisers for the invite to come and talk to you today about the Floella clinical trial. So, I'm Mark Edwards from Southampton, leading this very large randomised clinical trial, which I'm sure many of you in the room are involved in. Just to quickly put up some disclosures, and before I forget, just to acknowledge a quite amazing team of multidisciplinary specialists who are helping to drive this project. And we're grateful to them. The sponsor, Southampton, the funder is the National Institute for Health Research, and we're enjoying industry support to help make the trial feasible, so we're grateful for that as well. Okay, so the working title for the talk is 10 Reasons Why We Need the Floella Trial, because I think hearing about a lot of quality improvement around emergency laparotomy today, you might be wondering, where does this fit in with the whole picture of that? It was interesting to hear Neil talk about difficulties and arguments and disagreements around the role of goal-directed fluid therapy in this intervention, and I hope we can help with that. So the slightly longer title is, just in case you're unaware of the Floella trial, is 10 Reasons Why We Need the Floella Trial, which is a large, nearly 8,000 patient and 100 hospital, pragmatic, open, randomised controlled trial of cardiac output-guided hemodynamic therapy given during emergency laparotomy surgery and for 6 hours afterwards, which we're comparing with usual care without cardiac output monitoring to see if it will reduce death at 3 months after surgery, using a fairly novel, efficient and cost-effective trial design based on NELA as our data platform, which is currently up and running in nearly 40 centres, and this morning recruited its 400th patient, and will continue recruiting on hopefully a continued upward acceleration until 2020. So, first reason, I don't need to go over in too much depth. I think most of us in the room appreciate the significant healthcare burden associated with patients going through emergency laparotomy surgery. It's a common procedure, nearly 30,000 cases a year in the UK, with, in the over 50s, a 90-day mortality of around 20%. It's a shocking amount of morbidity and mortality associated with this procedure, and we need to continue to strive to improve outcomes for this group. Secondly, we know, because we've been trying it for a few years, that we have a hopeful candidate intervention that might help this group. And this is, of course, perioperative cardiac output-guided hemodynamic therapy. And this is the largest and probably most robust evidence synthesis that has been conducted of this intervention, which is the Cochrane review, which was updated with the results of Optimise most recently. Obviously, more trials have come out since then. But looking at one outcome in those trials, which was mortality at longest follow-up, the suggestion is that patients going through surgery who are exposed to this intervention have a relative mortality risk of about 15% less. But that's not a significant change, and obviously there's a lot of very different trials within that data set. But it looks hopeful. However, there are no good-sized randomised controlled trials of this specific intervention in patients undergoing emergency abdominal surgery. There are some contained within those studies there, but the total numbers of laparotomy patients going through in those trials probably is only in the region of about 100. And none of those groups or subgroups in the more elective clinical trials have been big enough to allow adequately powered subgroup analysis. So we really haven't got a feel for how this intervention works in this specific group. And that's why we see things, for example, like in the Cochrane summary, that there's a strong recommendation there's inadequate data in this group and that further information is needed before drawing firm conclusions. And it's also why NELA have taken the view that although they collect data on this at the moment, they do not view this as a quality standard. It is not something that they recommend as routine care at the moment, based on the lack of evidence for it at the current time. Does that matter? Can we just drag that evidence from elective surgery, which is still controversial, I think we have to admit, into our emergency laparotomy patients? And I think we do need to take stock of what our emergency laparotomy patients look like pathophysiologically and from a fluid point of view. We know they have often sepsis, capillary leak, systemic inflammation. They may have been bleeding. They may have had bowel obstruction and fluid shifts for days at a time. They do not look very much to me like my elective 60-year-old, enhanced recovery pathway, barely fasted, laparoscopic colorectal resection. They look very different to me. This intervention may have a bigger effect in this group, or it may have a lesser effect. Let's look to critical care. What do we know about this intervention in sick critical care patients, such as those with early sepsis? Actually, the literature there is much more negative. And there's even, in some studies, a signal of harm in critical care populations given fluid optimization with these sorts of strategies. So the strong argument behind Floella is that this group is unique in terms of its pathophysiological qualities. It may respond differently to this intervention, and although the intervention looks hopeful, we cannot say that it will be beneficial in this group until we look at this group specifically. And I think this status is reflected in actually what clinicians are doing. There is uncertainty out there about whether we should be using this or not. And we've got very useful data from Neela. The state of play is that usage of this stuff varies dramatically across the country. This is the year one report. And on average, 37% of patients were receiving cardiac output monitoring. That went up slightly, 39% in year two, and back down to 37% nationally in year three. Okay? This is what a picture of community equipoise looks like. This is the situation you need to support a clinical trial looking at an intervention. And of course, we did development work before we started Floella. We were asking clinicians who were involved in laparotomy care, what is the barrier to you using this more? Why aren't you doing it? And there were some other reasons like financial or training or equipment availability. But the number one reason for not doing this routinely was that people did not believe in the evidence for it. And the vast majority of people who we surveyed said they would be happy to randomize their patients into a trial looking at this intervention. So we have an intervention. It looks hopeful in a different group, but we don't know the effects in this group. Should we transpose across and just start using it, or should we trial it? And the real concept here, which I think is very important, is that if you can trial an intervention to see whether it's effective or neutral or harmful, if you can do that, then you should. Because we owe it to our patients, we owe it to the clinical community to know whether the treatments we're using are beneficial or not. Because these treatments, when you do them properly, they have some financial implications, of course, they have some costs, but also have resource implications. If you do goal-directed fluid therapy properly, not just switching on the monitor, but actually going through a structured algorithm, okay, it takes some effort. And that's fine and right. These are sick patients. They deserve that resource if that's the right thing to do. But it does require some effort, and it's important for us to know if we should be pursuing that. So how are we going to test it? And again, it's not a very fashionable way of doing things at the minute, but it is the gold standard, and we know this, the gold standard for comparing two treatment approaches is by randomizing patients in a controlled clinical trial. And Paul alluded to this morning, but there is a huge amount of robustness and power that you get by randomizing large numbers of patients into trials. So the noise that you get in the perioperative setting, variations in care, we do things differently in this hospital than the other. All these differences, once you go beyond randomizing a few hundred patients and randomize thousands of patients, as we are doing, those differences equalize and melt away. It's like noise-cancelling headphones. All that background stuff equalizes, and what you're left with is differences in just the intervention that you are studying. Okay? It's a wonderful and elegant thing, and we should not turn our back on it. So randomize large numbers of patients. The other thing that you can do when you get that is that you get proper confidence about the treatment's effects that you're finding. Now, the Cochrane suggests a 15% reduction in death rates. That is a small difference, and it sounds small. But actually, you scale that up across all the laparotomies we do. If this is positive and it works, and we use it routinely, that equates to something like 700 lives a year. Okay? So very much worth pursuing. But you've got to go big to detect that difference. Okay? A small randomized trial will not tell you that answer. It will not have the size and the power to detect that difference confidently. Okay? So randomize large numbers of patients. And doing that through a registered trial structure brings a huge amount of robustness to your results as well. We go through immense scrutiny. We have to pre-register protocols and then stick to them. We have to pre-register and sign off stats analysis plans to say what we're going to do with our stats now and then do it. Okay? There's external peer review. There's data sharing after publication, so people can try and reproduce our results. Seventh reason. We've got a pragmatic design. That means it's got broad inclusion criteria. It's partly delivered by clinicians. It's a real-world setting. We're trying to close that gap between the trial data and the actual pathway of what people do. What are the benefits? When the trial results come out, the patients you will see in that study look like your patients, okay, because we've got broad inclusion criteria. There's great generalizability. We're pragmatic. There are certain things we're strict on the protocol, but there are other things where we know it's real life and it has to work in the real world setting. So people have got a bit of flexibility, choice of fluid, choice of monitor. Okay, so there's great buy-in by clinicians, and it helps us deliver it. But rapid translation. Okay, even today, probably I think 4 or 5 patients will have gone into this trial. Think about how many people, how many members of the clinical team will be getting hands-on, delivering this intervention, getting familiar with it. Okay, and that's happening across the country. If this is a positive result, it's going to be much more likely to be taken up rapidly into clinical practice because we know it works in the real world, and it's us that's been delivering this and getting familiar with it. That gap can shrink. Okay, we've developed an algorithm quite carefully with an expert group. We've looked at prior literature, seen the protocols that appear more effective, and refined them based on evidence that has been published. 9th reason, we've got a super efficient design. So the NELA data platform is an amazing attribute. We're able to build in a few questions on that, and we've got a trial data platform, which is such a powerful thing, and it's already embedded in our clinical lives. So we've been able to study, or propose to study, nearly 8,000 patients for about £1 million worth of research funding, which I'm not aware of any better value interventional trial that is out there. Okay, a per patient cost of about 140 quid. It's pretty unprecedented. Okay, but it also means because we're not cumbersome, we're not doing lots and lots of different follow-ups, we're not doing extra blood tests, questionnaires, it's just mortality and a simple intervention. This means that we can do this. We shouldn't be scared of big clinical trials if they're light touch, if they're easy to do. Okay, it just makes it just part of day-to-day work. You can do both. Okay, we view this as a well-circumscribed, discrete intervention within a broader package of care, but there's absolutely no reason within that context why we shouldn't be looking to improve everything else we do with these patients. Okay, and we're keen to work with all the projects that are looking at quality improvement in this group to work together to make maximum success for both projects. So, we can still be doing all that stuff, and actually the trial, again, because of its size, because we're very well powered, if there is an ongoing downward trend in mortality, as we've seen so far, we're protected against that in terms of the power of the trial. So that's not a concern, and that is good for our patients. I couldn't squeeze in 10, so I went spinal tap and turned it up to 11. Here's an important point. If you're presented with a Floella patient to deal with, and perhaps it's the first time you've come across it and you think, what is this crazy stuff? Is this some fusty academic exercise that these people are doing for their own professional benefit? No. Okay, this topic has been prioritised by patients in public in consultation exercises. We've had patients on board in the trial development who've told us how they think we should consent patients and what outcomes are important. The NHS funders put this through the mill. You have a year's worth of rigorous application systems. They don't fund trials they think are unnecessary or poor value for money. Rigorous external peer review, support from NELA, a highly experienced multidisciplinary trial group, and approval by a research ethics committee who says this is a perfectly reasonable thing to ask patients to do. But most importantly, your patient will have given their informed consent. They've been told about the trial, told about the background, and asked, are you happy to be randomly allocated to one treatment or another? And they've said yes. They've given informed consent. They wish to be randomised. Okay? And that's a really important thing. We're supporting patient choice, looking after patients in this trial. I will finish with that important message. If you are in a NELA-positive hospital, please ask yourself, if you're not already, why are we not supporting this trial? And if you can, please do. Thank you very much.
And don't forget you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out ebpom.org for more details. ebpom.org. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Masters Course, Perioperative Care Practicum. Between the 28th and the 30th of September. ebpom.org for more details. That's ebpom.org.